Today I'm going to share with you my conversation with the amazing Dr. Corinne Menn. Now, we had an almost 2-hour conversation, so I've decided to split this video into two. So part one will be today, part two will be tomorrow, so I hope you will tune into both. Dr. Corinne Menn is a NAMS certified OBGYN. So that means that she has certification from the North American Menopause Society. She is an expert in menopause. She does work with MyAlloy, and I'm really excited about that because they have a ton of menopause experts on staff, of doctors that are menopause experts. And the deal with MyAlloy is they are a service that is there so that you can get education, information, and you can also get prescriptions if you want to. Now, I think that this service is super important because what I have found since doing these videos is that women have trouble with access to menopause related healthcare. They have trouble with access to HRT if they want it. They have trouble with access to the right information. And information is everything so that you can make the right decision for yourself. Everybody doesn't need to do the exact same thing, of course, but everybody should have the right information, the truthful information, so that they can just make the best decisions for themselves. What started as me looking at a face cream that contains estriol, and I think that's awesome, became this kind of like, wow, this is an amazing service for people. Now, Dr. Menn is one of the menopause expert doctors that is there. And the cool thing about this is once you're a member there, you have unlimited access to those doctors to answer your questions, to message with them. I mean, that is incredible. Even if you don't want to use their services in any way, if you get the information from them, you will be better equipped when you go talk to your doctor with the right information. Okay, I'm going to be done with this diatribe here, and I will see you on the other side. If you could introduce yourself for the audience who may not know you.
Absolutely. So I'm Dr. Corinne Menn. I'm a board certified OBGYN and a Menopause Society certified practitioner. They just changed that terminology with the formerly known North American Menopause Society, now the Menopause Society. And I have been practicing for over 20 years. And really over the past decade or even a little longer, I've really focused my practice on GYN only, and really specifically the care of women in perimenopause and menopause, as well as breast cancer survivorship and taking care of women who are at higher risk for getting breast cancer. And I think it's really important to know that my background is that I was diagnosed with breast cancer when I was in my training, when I was 28 years old, a second-year OBGYN resident. So it really informed how I, practice medicine, and, it changed my life personally and professionally. And now currently I see patients privately in my own small private telehealth practice, as well as being a medical advisor and doing a lot more telehealth on the Alloy platform. So that's what I'm doing now.
Can we start from the basics? Could you explain perimenopause, menopause, post-menopause? What does that even mean?
These are life transitions and times of your life. So, you've got pre-puberty, your childhood. Then you've got puberty, and there's that change, and there's, a time span, right? Once you've gone through puberty, those are your reproductive years. So you want to call them premenopausal? Sure. Or just your reproductive years. And then there's this transition time. That's the perimenopause, when you're transitioning to the menopause. So, this term of postmenopausal, it's probably a bit semantics, right?
Mm-hmm.
But the reality is, women will live a large percentage of their life after they've gone through the menopause transition. So you could say you're menopausal for the rest of your life, or you're in postmenopause. Again, it's just a label. But the perimenopause is the most interesting because it's truly a transition, and it's really misunderstood, and it can last up to a decade. So that's a big chunk for a lot of women. And since the average age of menopause is 52, you're talking 10 years earlier, but that's the average age. So some women go through menopause at 47. So that means they could be starting changes in their late 30s. So, Doctors don't even realize that.
Yeah, perimenopause, I mean, because that's clearly where I am. I'm going to be 50 in just a few months. And I've obviously noticed some changes and stuff. And what is interesting to me is I feel like it's so ambiguous as to what to do because you still have your period. So there you are, but you're experiencing these symptoms. And so it's kind of like, well, what point do I address the symptoms, even if I'm still having my period? Like, that, because obviously I'm in a decline of estrogen, I mean, there's got to be this bridge area when you can, start. And we'll get to this, but I was going to ask you about that because I'm curious about, this is sort of specific, people who are perimenopausal at risk for clots, but recommended to go on a low dose pill, which is not supposed to be for clots. And so what are they supposed to do to bridge the gap between perimenopause and when they actually enter into menopause? We don't have to get into specifics, but that is just one of those things that got me thinking,
No, it's a really important thought. And listen, there's lots of guidance around how we can help women with perimenopause. Unfortunately, a lot of OBGYNs really don't know. I think the perimenopause is almost harder for them to deal with. And you bring up a really interesting point that we are always talking about how the low dose birth control pill, I always like to say it's could be called like the perimenopause pill because it does help a lot of women. But we also know, to your point, that there's a lot of women in the perimenopause who have comorbidities. They may have other things going on. Maybe they're a smoker, unfortunately, or, maybe they have some other medical conditions that really are saying that you shouldn't take the birth control pill, and understanding there's a reason why, because the birth control pill has higher, more potent synthetic hormones in it. And so kind of the rules on prescribing are a bit different than using low dose menopausal, often bioidentical, but FDA approved bioidentical, often transdermal. Those risks aren't the same as with, the birth control pill. But because it's labeled menopausal hormone therapy, doctors and patients think they can't use it in the perimenopause.
Right.
Not true. There's lots of great uses of progesterone and estradiol in the perimenopause, amongst other things, of course.
It just feels like this really gray area. It literally a gray area of my life right now. You know what I mean? It's so strange.
It's a shame because symptoms start bubbling up then. And if you're proactive, you can really get ahead of things, right? And not everybody wants to be on a birth control pill. While I recommend it to lots of patients who are in the perimenopause, and it can help a ton of women, for some women, it doesn't agree with them. They may have contraindications to it. They may not need the contraception and really just want something different. And the fact that no one is talking about how to properly cycle you with progesterone or, use a low dose, estradiol product, is kind of silly, really.
I would love to talk about symptoms because most of us know that the common symptoms like hot flashes and even sleeplessness, stuff like that. I would love to pick your brain on the other symptoms that exist that maybe people don't realize are a symptom of menopause or perimenopause, et cetera. The reason that this comes up is probably in the last year and a half, my ears started to really, really itch. And it was only, I don't know, in the last month or two that I realized that that's likely some kind of a symptom because of my skin being dry or, whatever. And then also there's other symptoms of anxiety, et cetera, that I think a lot of people don't realize are, a symptom of this. If you could give us some symptoms that are maybe a little off the beaten path, that might be aha moments for some people watching.
You're totally right. There's tons of symptoms that people don't recognize beyond hot flashes and night sweats, right? And often in the perimenopausal woman, they won't have terrible hot flashes until their estrogen levels really, really drop. A lot of the other symptoms start to be, come into play in perimenopause, mainly because of the very irregular and erratic hormonal secretion. And those kind of symptoms that we don't often talk about, heart palpitations, racing heart, huge one. Certainly skin changes, dry skin, thinning of the skin, skin changes, not just in the vulva and vagina, but really anywhere. Increase in vertigo and tinnitus in the ear, and then mood stuff. anxiety, new onset of like ADHD like symptoms, difficulty concentrating. Those are like big ones that women kind of write off. And doctors write off too. New onset of joint pain or problems with the shoulder, they send them off for, other specialists. Also, new onset of headaches. I've had, or the combination of headaches and brain fog symptoms have some women sent off to get like MRIs of their brain. Like, can someone ask her a menstrual history and ask her a menopause inventory of symptoms? And let's treat like the obvious before we go down the road of scaring her that she has a brain tumor. Like, come on.
Right. On that note, is HRT something that could effectively treat all of those things?
Absolutely. Yes, absolutely. And certainly, and I always like to, and just off the bat, I don't think that the HRT is like the cure all for
Sure.
everything. But the reality is, we have something that's super well studied and safe. We've got really clear, guiding principles on how to prescribe it. And it's just one of many tools that you can have. And I don't understand why it's not used.
Under my last video, there were so many women who were, lots and lots of women were like the aha moments for them. And then lots and lots and lots of women were over and over saying how their doctor would not hear it from them. They wouldn't, their doctor just said no, and we're not going to talk about it. And I can't believe that still goes on now. That is so crazy to me. And I mean, I said it several times in comments, well, you should probably find another doctor. I mean, that's how I feel, but
It's paternalism. It's not shared decision making. Doctors' jobs are not as gatekeepers. They're supposed to be there to help us make decisions. And, lots of things change when we age, and we address that. Like you said, people get diabetes, or, people have blood pressure problems, or they break a leg as they get older because of osteoporosis, or a teen has hormonal changes at puberty and you do something, sometimes a birth control pill to help with the acne. So there are natural transitions that happen, natural processes of the body that happen, and modern medicine has come up with ways to alleviate that. So there shouldn't be any guilt that we're treating something that's natural, because guess what? Getting old is natural. Getting cancer is actually natural. We have treatments for it.
right.
So if you're suffering from your menopausal symptoms and it's causing a disturbance in the quality of your life, or you have risk factors that you want to use it for preventive purposes, then by all means, this is an excellent option. And why it's denied is actually unacceptable, and it just needs to stop.
How important do you think sleep, exercise, diet, etc., are in the management of our menopausal symptoms?
They come first, really. Like, I can give you an estradiol patch and progesterone, but if you're doing none of those other things very well, if you're not focusing on your sleep, moving your body, lifting some heavy weights, nourishing your body, not starving it, doing the right things that we can speak about. Go back to listen to Dr. Haver. I know she talked all about that. Then it's going to be harder for the HRT to help you. But on the flip side is I think it's kind of cruel to say to a woman, you have to do these things first, and then if they don't work, we can do HRT. Because I have so many women who literally, they are up all night. They are suffering. They wake up in the morning, they don't feel like, exercising. They are going to have food cravings, because when you're tired and cranky and depressed, their joints may hurt. There's all kinds of reasons why, they're not able to do all those great preventative things. So, I think it has to be a combination,
Yes.
right? And I see a lot of women being like denied HRT because, well, you just got to lose weight first, or you've just got to focus on your sleep and stop the screen time. I'm like, let's break the cycle,
Yes.
with as many tools as we have. Yeah.
I would love to talk a little bit about mental health when it comes to perimenopause. And the question is, what percentage of women are likely to experience anxiety, depression, panic attacks, etc., due to the decrease in estrogen? And is this due to fluctuations in estrogen or low estrogen? And how helpful is HRT in dealing with those symptoms, if you will?
Big area of interest for me. So in terms of the actual percentage numbers out there, I looked at this. It's kind of all over the map, but it's probably at least 50% of women, right? And because it's so under recognized, by doctors and patients, that's why it varies in the literature. But when you look at reviews of perimenopausal mood changes and hormonal changes, there is a very strong association, in particular with what you mentioned, the transition, the erratic, irregular secretion, and not necessarily as strong with the ultimate, decrease in the estrogen, which, yes, we do see that. But, studies have shown that women who have a history of PMS, have a history of PMDD, premenstrual dysphoric disorder, which is even like more mood changes before their periods, women who had postpartum depression, women who had just a diagnosis of clinical depression or generalized anxiety in the past. When she goes through her perimenopause, she's at a much higher risk of having a resurgence of symptoms or a new diagnosis of, a mental health issue. And unfortunately, the knee-jerk reaction is often to put them on, a psychotropic medication, which can be life-saving. And I'm not discounting that. But you have to look at the bigger picture. And, the NAMS guidelines actually have, very clear statements on this. And there's tons of literature and data. There's one really good article, which at the end you can link to your audience because it's very scientific, but it's really the best review article I've found on this. And it's just quite remarkable how beneficial treating those perimenopausal symptoms with estrogen therapy, can be. It can stave off the onset of a new diagnosis of depression. And it can even, for women who are already on an SSRI or some other medication for their depression and anxiety, adding a little bit of estrogen can make it work a little bit better, And in some data has shown that women who have new onset of anxiety and depressive symptoms that are, just very clearly linked to these, perimenopausal symptoms, that that estrogen therapy is superior to the SSRI, So, and I think that getting back to like the sleep issue that you brought up, like, I think a lot of the mood and depression and cognitive changes and anxiety, a lot of it stems from like chronic sleep deprivation,
Sure.
which we know is a risk factor for depression. So it's intimately linked and completely under-recognized, even by the GYNs for sure, and also the psychiatrists. Like, if you're a psych taking care of women, you just got to know this.
I feel like this is such an important conversation because people can feel like they're going a little crazy or that, it's not, I will tell a little tiny personal story. Nancy knows this. We were flying to San Francisco just like a month or two ago together. And we were on the plane and we were just chatting, Nancy and I, and we were having a completely benign conversation. She was telling me some fun story. And I had inside, I didn't tell her, a complete anxiety attack. Like I could feel like I was about to go on stage and do some kind of public speaking and I was freaking out. And twice on that short airplane ride. And I think I told her like the next day or something, I was like, this was really weird. And she said, that's probably perimenopause. I had no idea. I really was thinking to myself, what is happening to me right now? And I'm telling myself, stop it. You're fine. You're fine. There's nothing wrong with you. Like, why are you doing this? In my head, I feel like all this research I've been doing, if I had no idea that could be, I can't verify that that's what is going on, but I'm guessing that's probably got something to do with it. And I just think, oh my gosh, if that's happening to me and I'm feeling that way, there's got to be a lot of other people who are like, what is going on? What is happening right now that I'm having these moments, when it's so treatable.
And it's coming at a transition in women's lives where maybe their children are getting older. They've been married for many years. Maybe they're having some relationship changes and interest. But like the mood stuff, when I'm trying to explain it to my patients, I'm always like, either you have a teenage daughter or someone who has a teenage daughter, or you were once a teenage girl. Do you remember what it was like in puberty when you were first getting your cycles and the PMS and the emotionalness? It's the same stuff on the other end. It's just another hormonal transition. And so it's actually kind of surprising that like more doctors don't really understand it, because we talk about it all the time with like the
Right.
teenagers changing, you know? So, you know, this is just the other end of your reproductive kind of span of hormone production, doing the same thing, only in reverse, right?
That makes total sense. That's
I
a really
mean,
good way to look at it. So, progesterone. Could you let us know if there's any risk on progesterone? When I was talking to Dr. Haver, she made some reference, I believe it was to the WHI and the relationship between progesterone, possibly progestin, I could have those mixed up, and breast cancer. And is there any relationship? Should people be in any way worried? And what could you explain progesterone?
so this is super important. And this is why, you know, the WHI, while we learned a ton from it, it's not all bad, but the communication and the messaging was very poor. And it's still tricky to this day, because the WHI, women have to remember, they use synthetic equine estrogen, conjugated equine estrogen. And in the arm of the study for women who had a uterus, they used a synthetic progestin, medroxyprogesterone acetate. We tend not to use that progestin as much anymore. I'm not going to vilify it, because even that, we'll talk about the risk of breast cancer there. So so people throw the word progesterone around a little too loosely, right? When we're talking about it, we have to be a bit more nuanced, because the synthetic progestin is different. And countless studies since the WHI, as well as the WHI, have shown that, right? So let's talk about the big pink elephant in the room, the breast cancer risk. So we've heard a lot about how in the estrogen only arm of the WHI, there was not an increased risk of breast cancer. In fact, there was a decreased risk of breast cancer and a pretty up to 30% decreased risk of ever dying of breast cancer. So that was super powerful. So then everyone's like, well, it's the progesterone. Well, actually, it's the progestin. Okay. So the progestin, medroxyprogesterone acetate, in the WHI. So at the worst, what it showed was that, and some people think that this was not even statistically significant, but let's say that it is. It was one additional case of breast cancer after 4.5 years for every 1,000 women, taking that. And that was only in the older population. Okay. So that's considered a rare event,
Okay.
less than 1 in 1,000. So now but remember, that was synthetic progestin. So the question is, well, wonder if they used oral micronized, FDA approved progesterone. You don't need it compounded. It's not in a cream, oral progesterone. So studies have looked at this, and at the North American Menopause Society conference this past fall, they presented this article. Dr. Heather Hirsch presented it as one of the top 10 things to know this year. And it was a review article looking back at formulation. And in the end, formulation matters. So the article just basically said, estrogen alone, we don't see increased risk of breast cancer. Estrogen with the synthetic progestin, what I just said, a slight increased risk, but we have to take it in balance of other decreased risks when used in a younger population, like in the first 10 years of menopause. And then what was the most interesting thing about the article was they looked at progesterone, real progesterone used in formulations. And looking at the data, it showed that there was either a neutral or a positive effect in maybe slightly lowering the risk of breast cancer. So to me, they're just two different things, and you can't use the same word. And it's so confusing because people don't even know how to talk about menopause to begin with. So then when you get into these words, it gets really confusing. But I think if you just remember, formulation matters, and remember, with estrogen, it matters too, not as much for the breast cancer risk, but for blood clot risk and stroke risk, right? The blood clot risk is really associated with oral estrogen, and is really dose dependent. So higher doses, higher blood clot risk. Transdermal estradiol in a patch or like a divvy gel has never been shown to increase blood clots. I prescribe transdermal estradiol all the time for people with factor V Leiden mutation, other, prothrombic gene mutations, even women who have had a history of a DVT in the past
Mhm.
can use it. So, formulation, formulation,
Right.
formulation.
I figured it had something to do with progestin versus progesterone, and it is confusing. I mean, it's really confusing. And I had a lot of people come back and say, well, my doctor said progesterone is protective. And I thought, I'm definitely going to ask Dr. Menn about this because,
And but it's really important that women aren't completely scared by the synthetic progestins. We now generally use norethindrone acetate as the alternative progestin. And then there's the progestin that's in the Mirena IUD too. That the Mirena IUD progestin, which some people use as the component for their HRT, that's not really, you know, not a lot of systemic absorption. That's quite safe. But even the norethindrone acetate, because some women do not tolerate oral progesterone. You can use it off-label vaginally if you don't tolerate it, if it makes you too sleepy or it makes you have some GI effects.
Mhm.
And so you can use it as a vaginal dose. You just take the same capsule, pop it up in the vagina nightly. Works beautiful to protect the lining. You're not going to get the same sleep benefit, right?
Right.
But some women, they just don't, tolerate the progesterone. They don't want to use it vaginally. And norethindrone acetate in a combination product like Combi Patch or Activella is quite safe. Remember, the old, even in the WHI, and many people argue that was manipulated to make it appear statistically significant when it was not.
Right. I feel like the term increased risk should have to correlate with statistically significant, because 1 in 1,000 additional does not seem like increased risk to me at all. And so, but nobody
Yes.
quantifies increased risk as a general population. They just hear increased risk. Nobody goes back and says, what does increased risk mean? It just means to the average everyday woman, that means I'm a bigger chance of getting breast cancer. Don't want it.
And if people look at the NAMS position statement, they actually, in the very beginning of it, they talk about how to quantify risk. And, in science, there's levels of like how the label it is extremely rare, more common. And all of these risks that we're talking about all fall into the rare risk. Okay. And actually a lot of common medications that people take have much more frequent risks
Right.
that people don't even think about. So
Right.
for some reason, this has been very has become this taboo thing.
Vaginal estrogen. This one is so important to talk about here because I know you are an advocate or a proponent, but I would love to talk about. I'm going to mispronounce this. Genio to
Oh, okay.
yes,
Do
that
you
one.
want to talk about genitourinary syndrome of menopause? It's such a
Yes.
sexy term, GSM.
Yes.
It used to be called postmenopausal vaginal atrophy, which is equally unsexy.
Yes,
But
it is.
so, break down the words genitourinary syndrome. So it's genital changes, so changes to the vulva, the vagina, the clitoris. Yes, the clitoris too, your urethra and your bladder, okay, and the pelvic floor tissues, okay, the skin on the outside, the skin on the inside, okay. So let's just say GSM changes, kind of where they're really clinically overt. I'd say it's often one of the later changes that women will complain about. Up to 80% of women will have some. I think probably 100% people just don't even know what to call it. So you'll see up to 80%, but very few, less than 20% actually treat those symptoms because they don't even kind of think that it's due to menopause. And it's really a shame because it's so easy to treat. So symptoms like more frequent UTIs, feeling urgency to go to the bathroom, more frequency, not necessarily stress incontinence, like when you cough and sneeze and then you pee a lot. That could be because of pelvic floor damage. And then certainly vaginal dryness, but it's not just vaginal dryness, it's decreased sensitivity to sexual stimulation. The clitoris literally gets less blood flow and can shrink a little bit. Imagine if men's penises shrank, like all over that. Well, they kind of do because 40% of men by age 50 have some type of erectile dysfunction, and we have all these medications for it.
Right.
Well, probably 80% of women around midlife are having GSM symptoms. And, they just think of it as vaginal dryness. They don't think about all these other things. And then they wonder why sexual activity isn't as pleasurable or they're not as interested in it. Well, if it is not comfortable, you're not going to be interested in it. You got to treat the pain first, but not just the pain, this idea of lack of or diminished sensation, diminished ability to orgasm. These things are all linked to lower amounts of estrogen and testosterone androgens, in your pelvic floor.
Setting sex aside, why would a woman, I know you kind of went through it, but why would a woman want to use vaginal estradiol? Is it estradiol?
There's different versions, but yeah, vaginal estrogen.
So what could it help? Let's just go over that again. What could it help alleviate for her medically that she may be able to actually notice in her life better?
Yes, absolutely. So, it's FDA approved to treat and prevent genital urinary syndrome of menopause. I just mentioned the prevent because if you're a perimenopausal woman or you're newly to menopause and you don't have a ton of those symptoms going on yet, you can use a little vaginal estrogen twice a week, and that can really prevent these changes. So you would benefit from, less of the urinary symptoms. A lot of women at midlife say, oh, I'm getting all these UTIs suddenly, or after sex now, like my doctor says, I've got to take an antibiotic prophylactically because I'm getting so many UTIs. I'm like, no, you can just take vaginal estrogen, So for the urinary stuff, for sure. And then for just all of the sexual stuff, sensation, lubrication, comfort, pleasure. And even if you're not, so there's a lot of women like, well, I'm not sexually active, so it doesn't matter. Well, you don't know if maybe one day you might want to be sexually active and you want to wake up to like a totally
Yeah.
really sub-optimized
Yeah.
genital tract. But for the urinary health alone, Dr. Rachel Rubin, big, urologist, Kelly Casperson on social media, they're constantly talking about it. Like literally, GSM changes actually kill women. Older women go to the emergency room for UTIs and kidney infections and get sepsis. When I think back in residency, Penn, I would see older women in the hospital who were coming from the nursing home, and we were taking care of them for other GYN problems. And we would do a pelvic exam, and their vulva would be so thin. Some of them had ulcers. They'd have severe itching, discomfort. They were sitting in diapers. This is all totally avoidable. And it's insane that people aren't offered it. Right?
So who can and can't take it? The loaded question. Is there anyone who shouldn't use vaginal estrogen? If you are increased risk of breast cancer, if you have breast cancer, or if you are in treatment for breast cancer, any of those things, are they contraindications for vaginal estrogen?
Now, everybody can use vaginal estrogen. Everybody. There's a few cases where we'll be cautious. Very, very rare. If you had advanced endometrial uterine cancer, like stage 3 or 4, we'd want to make sure that, if you were new to treat, just had been diagnosed, we'd want to like run that by your oncologist. If breast cancer survivors can absolutely use vaginal estrogen. There's absolutely no literature that shows any increased risks. If you're using an aromatase inhibitor, which makes your estrogen levels super low, then you can use it, but you want to just be cautious that you're using maybe there's some lower dose versions. If you're using the vaginal estrogen cream, you're going to use a little bit less. You're going to certainly talk to your oncologist, but I'm going to warn patients that a lot of even oncologists are very misinformed on this. I actually have a link in my bio on my social media to a document that I made because it would make me so mad that women were being denied access, that literally links every professional statement, all the society statements from American Society for Clinical Oncology, ACOG, NAMS, you name it, saying that it's safe, it's effective, and it should not be denied to these breast cancer patients. Should not be denied to someone with active liver disease. It should not be denied to someone who had a stroke, who had a blood clot, who had ovarian cancer, who had a history of fibroids, like none of that. Everybody can use it and probably should use it.
And okay, let me ask you, is this something that if, let's say we have some people out there who are 12 years post menopause and they've never used any of this and they have some of these symptoms, will it go back and correct some things, or will it just be preventative from then on?
When it comes to vaginal estrogen, you could really, really return tissue quality. It's pretty remarkable. I'd say within the first 2 weeks, women will start to notice some changes. If they're very, very atrophic, it may take longer, up to 12 weeks to truly restore the health. And then you can't give up. You gotta keep going for life. You got to keep it consistent. You know, when you stop using it, the changes will go away. But yes, unlike severe osteoporosis or kind of permanent changes in your cardiovascular system or your brain, when you're like long, many years without estrogen, those we can't necessarily reverse that. That's a little bit more complicated. When we're talking about tissue changes in the genital tract and urinary tract, we really can. It's amazing.
I have friends who have parents who are in their 80s, and is this something that can be beneficial to them? I mean,
absolutely. So listen, some of the urinary changes you're not going to reverse with a estrogen cream. There's a lot of reasons why women can become incontinent, but at the very least, vaginal estrogen can improve the microbiome of the vagina, help kind of prevent not only vaginal infections but certainly UTIs, and also just help the resiliency and really the health of the tissue down there. You may return the skin health so that it can be a little bit more resilient in this, kind of compromised situation. I like to say I'm like a living laboratory, because I went through menopause really early. In my my late 20s and early 30s. I went through it 3 times due to treatment. Like periods came back, other treatment things happened. So I've been through it, but I've been kind of permanently menopausal since I think it was 33, 34 when I had my ovaries removed. And so I went for many, many years with no hormones. I am now taking a low dose transdermal estradiol patch and progesterone, and vaginal estrogen, but I experienced many years where I did not have that. And I can personally attest to all of the changes we've talked about today, from top to bottom, everything in between. And I can personally attest to, experiencing the profound improvement in changes when I was able to, with my doctor, with my oncologist, make decisions, share decision making for me to, use hormone therapy. And I should have always been using the vaginal estrogen. I just got lazy sometimes. And now I know if I don't use it for a few weeks, being lazy or I travel, I notice it. It's very different. And getting back to the older woman, one of the most common reasons why women present to their GYN with postmenopausal bleeding, often, people worry about uterine cancer. And of course, it's something we want to rule out. But the number one cause is postmenopausal atrophic vaginitis. I can't tell you how many these poor older women who, are sent to the doctor, these big uterine biopsies and ultrasounds, everyone's scared, a pelvic exam, it's so uncomfortable for them. Honestly, you should have just vaginal estrogen. And then you look at their vagina and it is literally terribly paper thin and severely atrophic and needless. And it's uncomfortable. You can imagine it's uncomfortable.
Yeah. I was wanting to talk a little bit about the connection between, having severe hot flashes and cardiovascular risks and that kind of thing, and the association with HRT, and how is it protective, and just that whole kind of topic, if you could explain some of that to us.
Yeah, so I think this is really exciting area of menopause management, and it was a big theme at the Menopause Society's conference in the fall. Tons of research being presented on this, and it's pretty clear that the earlier you start with vasomotor symptoms, meaning hot flashes, night sweats, and the associated sleep disturbances, the earlier and the more severe, the more likely it's going to last longer and be more severe. But also, the earlier you'll start to see these cardiovascular risk factors go up. So severe, or really any vasomotor symptoms, but certainly the more severe ones, are strongly associated with changes in your, cholesterol, atherosclerosis, hypertension, inflammation, you know, and heart disease, and actually death of, dying of heart disease, right? And what was really interesting is they presented data about actually what is happening when you have the hot flash. And they did a study where they were able to look at women who were even when they were sleeping, when they would have night sweats or hot flashes, even if it didn't wake them up, they were able to tell that their tiny blood vessels were constricting and changing, and they could measure that, and they could see that there was a decrease in how kind of elastic and how the blood vessels, the little blood vessels, responded, right, to blood pressure changes. And basically they were stiffer. Okay. And what they think is happening is at the very small microvascular level, when you're having these hot flashes, there's some associations with endothelial cell dysfunction. Those are the little cells that line all of our blood vessels. And there's some inflammation, some dysfunction, which can kind of predispose these blood vessels to, atherosclerotic changes, right? So, the question is, like, does treating the vasomotor symptoms aggressively prevent that from happening? Maybe. Yes. And it's probably part of the story when we talk about why in a much older woman, say someone who's not had hormone therapy for 10, 15 years, she's had all these changes happen. And then you give her estrogen in that setting, it's a little different, right? Than, giving it when you have this more healthy tissue. So, long answer to the question, but kind of bottom line is that yes, vasomotor symptoms are associated with increased risk of cardiovascular disease. And there's a large body of data that supports the idea that treating, ideally really within the first few years, really the earlier the better. Some will say definitely less than 5 years. We still use this 10-year window of opportunity to, to get some type of benefit. And we see that all of these factors can be improved: better, better cholesterol, less risk of, stroke, of heart disease, of diabetes, which diabetes in itself then raises your risk, less risk of obesity, all of these things. And what was also interesting is they found that even just the sleep itself, so even if you didn't have hot flashes, but you had disrupted sleep, that in itself was an independent risk factor for cardiovascular disease. So what I always find interesting is that I have patients who I see who are like, my doctor tells me I'm not a candidate because I have a family history of heart disease, or because I have some hypertension and I'm a little heavy, and maybe I have like diabetes. And so I'm at risk for heart disease, so I shouldn't take HRT. And it's actually reverse thinking. What you should say to that woman is, no, 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 you're in that first, 5 or 10 years of menopause. We should treat these symptoms because you are, yes, at risk of heart disease. And by treating your symptoms, we're going to help lower that risk and help you be able to do those other lifestyle things that will also, improve things. So it's like this weird reverse thinking. But it comes from these fears from that Women's Health Initiative messaging that hormone therapy causes heart attacks or causes heart disease. Couldn't be further from the truth when we're talking about the younger menopausal or perimenopausal lady, right? And so they're literally getting the opposite advice that could save their life in terms of heart disease.
All right. Thank you guys so much for watching. I do hope that you will tune in tomorrow. Have a really wonderful day. I'll see you tomorrow. Take care.